And one of the very popular sports in Australia over the summer is the game of cricket. And when I was a 10-year-old boy growing up, I was mad for the sport, and I had the biggest rivalry in cricket is when Australia plays England, which of course means when Australia was playing England in England, the broadcast would come on very late at night. So I would lie in bed with a transistor radio and an earpiece as a 10-year-old trying to listen to the cricket. And there was a commentator that was quite famous at the time. He was the voice of English cricket, a guy called John Arlott. And to listen to him explain matches on a transistor radio was very soothing, very peaceful, and he had a great way of making you feel like you were there live. Now, of course, as a 10-year-old boy trying to stay awake very late at night, he often put me to sleep, which I am certain our next speaker will not do. David Burney has been involved in orthodontics for many years. He has taught and practiced and is involved throughout the world as an examiner and teacher. David and a colleague of his, Nigel Harradine, have run an Excellence in Orthodontics course in the UK for many years, and many of the graduates there feel like that is a very important step as they transition from school to practice. David has always been current and up on the latest technologies and trends in the industry, and it is our pleasure to have him take over the second session. Thank you, David.
Colin, thanks very much. So my thanks to Colin, Sandra, Bruce, Lauren and Sue for arranging this meeting. It's great to be back in Bangkok again. Thank you all very much for being back from the coffee break promptly. I'm going to give two talks. The first is on posterior crossbites, and the second is on digital orthodontics made easy, which will be a sort of warm-up act for Sonia's talk after lunch. So just a little bit about myself. I work here. This is Newcastle upon Tyne School of Medical Sciences. Newcastle University is in the northeast of England. It's one of the top 200 universities in the world. We have about 25,000 students, but I don't do an enormous amount of teaching. Most of my time, I treat patients. So Newcastle was an industrial city. It was famous for shipbuilding. As shipbuilding declined, it underwent a rather black period, but has emerged as a regenerated urban environment, and it's a beautiful and vibrant place to work. But you might be able to tell from my accent that actually I'm not English at all, I'm Scottish. And I live here, which I think is the most beautiful city in the world, Edinburgh, and it's a fantastic, fantastic place to live. So I greatly enjoyed Frank Bogdan's talk yesterday, and I enjoyed John Lynn's talk this morning, and I don't have any argument with any of them. Just to say that I have done several orthodontic techniques. I started off with the universal technique, which most of you won't know about. I did beg, I did standard edgewise, I did straight wire, and I started using self-ligating brackets in 1987, which will be before the time that many of you were born. And I spent from 1996 to 2001 using Damon. And I used Damon completely wrongly. And in 2001, I went to Dwight's practice, and I sat in his sitting room in his house, having seen cases that I couldn't do with the techniques I was currently using. And in 2001, I switched to Damon completely, and I've done passive self-ligation ever since. So I'm actually a great fan of Toyota. I think Toyota are one of the most fantastic engineering companies in the world, and Toyota has 5 business objectives. And they're just as applicable to orthodontics as they are to making automobiles. And the first is we need to deliver quality care for our patients. We need to reduce the cost so we can make it affordable. And whenever we think of this, we tend to think just of our patients, but you need to think of your staff as well. So you need to provide a quality environment for your staff. You need to make your patients happy. You need to be happy. Your staff need to be happy. We need to shorten treatment times. And we need to ensure that the treatment we provide is safe. So just keep those in mind during the next 2 lectures. And I would just say what I'd like you to do is to relax. And over these 3 days, I'd like you to reflect. Some of the things that are said take a little bit of thinking about. But most of all, we hope you enjoy these 3 days enormously. So, managing posterior crossbites. Are expanders really necessary? So back in 2008, I asked my laboratory technicians to tell me how many quad helices and transpalatal bars I was using. And here you can see the results of the graph. And this, of course, is a dramatic demonstration of how Damon can reduce the number of auxiliary appliances that you use. And if you are persuaded by that, I don't think you had enough coffee, because it is not quite true. I didn't start using Damon full-time until then. So something else happened in my practice. So let's just combine the transpalatal bars and the quad helices together. This is a technique called statistical process control. It's widely used in industry to tell whether processes are delivering components within specification. And you can see that a dramatic decline in the usage of these auxiliary appliances. But something happened long before I started using Damon. Oh, let's go back. Sorry, let's go back. Just take a moment, let it. So something dramatic happened. So if on a statistical process control chart, you see 7 points that move in the same direction, that is statistically significant. Why is it statistically significant? Think of taking a coin and tossing it 7 times and it coming down heads all the time. The chances of that happening are 0.07%. So something happened to make me reduce the use of expanders. And probably what that was molar bonding. That it was just such a nuisance to ban molars, we found other ways of doing it. But there is no doubt that once I started using Damon, my use of these sorts of appliances reduced to nothing. So what are we dealing with? We're dealing with prevalence, we're dealing with diagnosis, we're looking at types of posterior crossbite, the effect on growth, and how we can treat them. So the epidemiology, the prevalence of posterior crossbites is about 14%, both in the primary and the mixed dentition. Most of them are unilateral. Most of them have a functional shift. And there's about 7% that appear and disappear spontaneously. If we look at those that have functional shifts, the size of that functional shift most commonly is between sort of 2 and 3 millimeters. Not many have a functional shift of more than about 3 millimeters. There are muscular compensations, and many of them will have apparent facial asymmetry. And often, the posterior crossbite is caused by arch deficiency. And the patient I'm going to show you now has arch deficiency, but barely has a crossbite. And the reason for showing you this is you can see that on the right, his upper canine is absent. It is in the line of the arch. But you can see, if you look very carefully, his maxilla is asymmetric. And the first thing that you can see, we'll have a look at that in a moment, the unilateral crossbites often have maxillary dental asymmetry, and we should measure that either on the model or on the photographs. And I think this is a phrase that I borrowed from Sonia, straight, centered, and symmetrical. And that's, I think that's a fantastic statement of what we want our cases to be. We'd like them to be straight, centered, and symmetrical. And if we look at Alex, if you look at his upper arch, you can see that it is not symmetrical. And one of the things is we need to learn to see. Firstly, you can see there is much more mucosal ridging on this side than on this side. So this is the constricted side. So there's the mucosal folding. If we drop a line down the median raphe, and then we draw arrows out to one side, and then transpose the same arrows across to the other side, you can see how much the right-hand side of this arch is constricted. So when we're dealing with posterior crossbites, look carefully at the upper arch. So you can see that the right-hand side has moved mesially and the molar has rotated. And it's easy to correct this by derotating the molar and opening the space for the canine. If you want, you can use a little tool. This is something called a hip analyzer, a Hamulus incisal papilla analyzer. So you can use that. And if you look at this arch, you again can see that the right-hand side is very constricted. In actual fact, both sides are constricted, because whenever you have an arch where teeth have been taken out, the teeth don't just track round the perimeter, they collapse palatally as well. So there's the left, and if you transfer those arrows across to the right, you can see where the teeth on the right should be. So if you have a crossbite and you want to close space, it becomes extremely difficult because the arch is already collapsed. The other thing that can cause crossbites is a low tongue position. Here we're looking at patients who have pacifiers, and here are digit suckers. And you can see people that have pacifiers tend to stop the habit much earlier than those that have thumb suckers. But the effects of the two are completely different. If you wear a sucker pacifier for less than 12 months, the effects are probably comparatively small. But if you do it for more than 48 months, you have almost a 40% chance of developing a posterior crossbite. Whereas if you're merely a digit sucker, that is much less. But you're much more likely to have an increased overjet. And the other thing to look at is patients that have short lingual frenums. So this was a study that looked at class 3 cases. And if you look in the maxilla, the intercanine width for patients with a short lingual frenum is smaller, the intermolar width is smaller, but in the lower arch, the mandibular widths are wider. And that's because the tongue never gets up into the palate because it's tethered by the short frenum. And in this study, the short frenum was only found in children who had crossbite. So tongue position is really important. So what's the short lingual frenum? If you open your mouth wide, or you get your patient to open their mouth wide, and they can't touch the tip of their upper incisors with the tip of their tongue, they probably have a short frenum. There are a number of papers that have talked about what to look for. I'm not going to do this, talk about this in any detail, other than just to mention that Lawrence Kotlow's paper, and more recently, Irene Marcheson's paper on a protocol for dealing with lingual frenums and understanding when they need intervention. So, if we're going to look and see whether there's a crossbite, we need to have the jaws approximately in class 1. John Lynn made the point this morning, class 3 malocclusions often make a crossbite look worse. Class 2 malocclusions often disguise a crossbite. And we have, when I started doing Damon, I was taught that the crossbite would correct itself with the arch wires. So you can see this patient here who has a premolar and a molar crossbite. But let's look at this patient. This is a patient that we'll look at in more detail in the next lecture, and she came to see me because she was concerned about the premolar crossbite on the left. If we look at her upper arch, you can see it's almost symmetrical. She has an equal number of teeth on both sides, so her problem is not maxillary. Her problem is mandibular. Her lower canine, left canines, tipped in lingually, and her premolars are tipped out buccally. And of course, that is very easy to correct just with the arch wires. So here she is in treatment. The crossbite has corrected easily, no cross-elastics, just with the arch wires. But if we look at this patient whom I treated just after having come back from Dwight's practice in 2001, and you can see that on the upper left, he has a crossbite, and in the lower arch, he has an interesting amount of crowding. And we decided to treat him as a non-extraction case because his father had one of the largest noses I'd ever seen. And we all grow up to look like our parents. And I thought that as he grew, his nose and his chin would grow and he would look fine, which indeed he did. But what we're really interested in is the crossbite. If you look at the buccal segment teeth, you can see that they're inclined lingually. You can't see the premolar on the left because it's tipped in so much. And what you're looking at mainly is tipping of the second premolar and the first molar. So there it is. You can see the problem. If we look at his upper arch, again, you can see some compression of the left-hand side of the arch. So we're not surprised the crossbite occurs on that side. And here I am in treatment. You can see that the lower incisors are beginning to sort themselves out, but the crossbite remains stuck as it was at the start of treatment. So 6 months into treatment, the crossbite persists. But as the second molars come through, you can see that they're situated buccally. And once they're through, we can bond the second molars. So this is the visit. We bonded the second molars. And immediately, the crossbite starts to correct. So the second molars provide the transverse anchorage that we need to correct the crossbite. So that's where he finished, and that's where he was 5 years after the end of treatment. Treated non-extraction, the lower incisor alignment remained stable, and the crossbite correction remained stable. So with this sort of case, it is often difficult, I think, to correct it just with the arch wires if they go back to the first molars. If the second molars are not in crossbite, engaging them make life very much easier. The other thing is we need to make sure that patients don't have any airway obstruction. So your patient should be capable of breathing through their nose. Mouth breathers have a low tongue position that causes collapse of the maxillary arch. If you want to check very quickly, are they mouth or nasal breathers, just get them to put their lips together. Their breathing should be light. You should hardly be able to hear it. You shouldn't really be able to see it. And we were fortunately designed so that when we breathe in, we take in more air than we really need. Otherwise, we'd spend all our life panting. So when you breathe in, you take in more oxygen that you need, and when you breathe out, you pause before you breathe in again. And that's called the control pause. So you should look and check to see that your patients have a control pause. If their breathing problem is functional, they just happen to habitually hold their mouths open, you can give them breathing exercises. But if there's any obstruction, then we send them to an ENT surgeon. So many posterior crossbites have a functional shift, and the functional shift is very important. Just to remind you what the bits of the mandible are, we have the condyle, we have the coronoid process, the ramus, the alveolus, and the corpus. And the purpose of those is the condyle is just there to maintain articulation. The coronoid process is there for the muscular attachment, for mastication. And the ramus provides the area that compensates and remodels. The alveolus supports the teeth, and the corpus supports the alveolus. And if there aren't any teeth, then the corpus simply joins the two halves of the mandible together. And when you think about what happens in the mandible, you should remember this sort of diagram. The mandible is suspended by a complex ring of muscles. And everything that goes wrong with the mandible is circular. So the mandible can't pivot around a condyle. Everything is circular because it's bound by these muscles. So when we have a functional shift, here's the non-crossbite side and the crossbite side. What happens is the mandible swings like this. It moves down, it rotates, and the other side rotates and moves backwards. And that means that you get positional asymmetry, and that results in dental asymmetry. The crossbite side becomes more class 2, the non-crossbite side becomes class 1. So we've said that the condyle is displaced laterally, superiorly, and posteriorly on the crossbite side, becomes more class 2, and the opposite happens on the other side. And if you treat these crossbites in young patients, the condylar position becomes symmetrical after crossbite correction. So if you have a functional shift, we talk about functional appliances and a belief that they may change the growth of the condyle. Surely if you have a functional shift, that might change the growth of the condyle too. But in very young patients, when you correct the crossbite, the condyles center themselves and the mandible shows no significant morphological changes. And that's true provided you're young. But look at this patient. She has marked asymmetry. She is much fuller on the right-hand side. She has a mutilated dentition. She has a crossbite. She was actually scheduled for orthognathic surgery. So she has a really difficult crossbite. And her asymmetry is probably a true asymmetry because she's now almost 40. Her mandible has been displaced for almost 40 years, and so the bones have adapted to that. So we decided to treat her with Damon, and this is where she ended up. It's not perfect. It's really difficult to get the right-hand side looking good, but actually it's much better than when she started. So for crossbite correction, what are the favorable prognostic indicators? Firstly, just because deciduous teeth are in crossbite, it doesn't mean that the permanent teeth will be. The first molars may be in crossbite, but it's really good if the second molars are not, because that gives you some transverse anchorage to correct the crossbite. It's good if there's a functional shift, because that means there isn't all that much discrepancy between the upper and the lower arch. And I would just say that if you have upper arch crowding, you've been told over the last day and a half not to extract. Please, please don't extract in a crossbite case with upper arch crowding, because you will make it just about impossible to deal with. And the other thing to look at is tooth inclination, because most of what we do in orthodontics is controlled tipping. So if the teeth are tipped in, it is easy to upright them. So there are lots of different methods for correcting crossbites. And really, there's only one or two that we need to talk about, because most of these are either the removable appliance is ineffective and you don't need many of the others apart from the arch wires only and arch wires, cross elastics, and disclusion, because most of what you're dealing with is tipping. So let's look at arch wires and cross elastics. So this is Patrick, and I think that I agree entirely with John Lynn, and far too many people go to have surgery. We send far too many people to the surgeons. Nobody wants to have surgery. I don't want to have surgery. I don't want my children to have surgery. So this is a patient. He was scheduled for surgery. He has a bilateral crossbite, and he has almost no overbite. I won't say he's got an anterior open bite, but he's edge to edge. So what do we see? The first thing is he has a very narrow upper arch. His tongue is not up in his palate. It's down in his nice broad mandible. The second molars aren't in crossbite. So that's a favorable sign. That's good. And the first molars and the premolars have tipped in palatally. So this should be easy to do just with passive self-ligation. So he's a very cooperative patient. We bond him up. I do most of my crossbite correction on light round arch wires because it's easy for the teeth to tip. And I'm quite happy to correct the crossbite by letting the teeth tip And I shall explain why that is a little bit later on. So we give him light round arch wires, elastics all on all the teeth in crossbite, right from day one. There you can see the crosses, just go back. There you can see the cross elastics in place. They're on the premolars and the molars. And here's where he finished about 16 months later. We closed down the anterior open bite. We corrected the crossbite without any expanders and just with the cross elastics. Here you can see the arches at the start, and you can see how much rounding out and broadening occurred in the upper arch, and in the lower arch, you can see that the shape has maintained the same. In fact, I treated this case with Insignia, and one of the things that you need to watch out for is that when you send this off to Insignia, they quite often send it back with mandibular expansion. And that's the last thing you want. You just want this lower arch to stay at the same dimension. And we'll talk a little bit about that in the next lecture. So why, when we've been taught that we have to use rigid appliances to move the teeth bodily, am I happy for the teeth simply to tip? Well, this was the paper that made me decide this was okay. It's from David Kennedy, who's an orthodontist and a pediatric dentist in Vancouver. They looked at patients that had had slow maxillary expansion and rapid maxillary expansion with a combination of appliances, Haas, Hyrax, and quad helices. And they took measurements at the start of treatment, at the end of treatment, and 2 years afterwards. And all these patients obviously had crossbites. So what did they do? They measured intermolar width and angulation, and they found that in terms of the relapse of the crossbite, it made no difference what type of appliance you used, whether you were male or female, the age they did the treatment, whether you used a retainer or not, and the amount of expansion. So there was no difference between the appliances. The expansion at T2 for all the appliances was about 5 millimeters, and it not surprisingly relapsed 1.3 millimeters. And the molars tipped during treatment, but then once the expansion was finished, they uprighted. So here were the ages at T1, T2, and T3. You can look at the intermolar width. It went from 42 to 47 and dropped back to just below 46. And the intermolar angulation started off at 155. Just think, if the molar cusps were exactly horizontal, the molar angulation would be 180. So 155 means they're tilted, tipped buccally. As they were expanded, they tipped more buccally. But during the 2 years when the expansion ceased, they uprighted and flattened out. And that's done by the occlusion. So I prefer to do my expansion on light round wires and then go into the rectangular wires, because most of the expansion can be corrected on round wires. Let's skip that bit. So, if you look at manufacturers, they have a bewildering array of elastics. I only use 6 elastics, and for crossbite correction, I just use these. Rabbit, 3.5 ounce, 100 gram elastics, usually. So that's my preferred elastic. So let's look at a patient. This is Alicia. So one of the things I said earlier on is that we need to learn to see. So look at Alicia's face. Our faces are quite different to the faces you have here. So you would never mistake this person from somebody from this part of the world. She is pale, pasty. If you look at her profile, she has a very retrusive profile. So there's her profile. Very thin lips. And even just looking at her face, whatever you see in the mouth, you know this is going to be a non-extraction case. But when you look in the mouth, you might think, how am I going to get those canines in? She has a bilateral crossbite. She has severe maxillary constriction. She has lingually inclined lower teeth. She has palatally inclined upper molars. And she has a pretty broad mandibular arch with mild crowding. And she has this bilateral crossbite. If we look at her kef, there's nothing very remarkable to see there. I bonded her up, and I quite often do this, picking up on something that Frank suggested yesterday. If I've got lots of crowding, I just put traction hooks on the teeth for a couple of visits. Let the teeth align. I want lots of interbracket span. What I would say is that this is a big mistake. This wire is far too deflected. We should have had a coil spring in there to open up the space. So if you see this amount of deflection, it's far too much. So too much arch wire deflection. We've got mini-mold lingual buttons made of composite here. We've got bilateral cross elastics there. We've got some disclusion on the molars. I think it's better to spread this across the molars so you almost make a flat plane. And here's some slightly different traction hooks which give you a bit more rotational control. Rather than putting an expensive bracket on there at the start that you have to move, just use a thick traction hook. So you can see now that we've corrected the bilateral crossbite with the cross elastics. We are going to use some triangular elastics just to level out the upper arch. We've got brackets where we had the traction hooks, and you can see the upper arch rounds out very nicely. And you can see, well, really the reason for showing you this is her amazing ear candy. I just dread it if my daughter came home like that. But actually, the other thing is you can see that her lips are much fuller now. So this is where we started. This is where we finished. The treatment took about 18 months to do. Very nice result. We went from here to here from October 2010 to April 2012. So, what about these cases have all been class 1? What happens if your case is class 2 or class 3? What do you do then? So, if we look at Alice, here you can see that she's class 1 on the right, she's half a unit class 2 on the left, she has a unilateral crossbite, and she has a functional shift. And here we are using an elastic that does two things at once. So the elastic goes from the lower molar, round the lingual button, and up here to the canine. And here you can see that the crossbite has been corrected, and she's moved into class 1. We still have a little work to do on the center line, but basically the difficult part of the case has been cracked. So with a little ingenuity, you can use one elastic to do two things. So we said that class 2 cases often have a virtual crossbite. When they're in the retruded axis position, they look as if they have a normal buccolingual relationship, but as the mandible comes forward, they look as if they're in crossbite. And that is because the upper arch in class 2 is not the same shape as the lower, but it's narrow and V-shaped. So we put some brackets on here. So green for low torque, red for high torque. And if you run your elastics like this, what you get is compression. You make the lower arch narrower, but you make the upper arch narrower as well when you want to make it wider. And Frank talked yesterday about the fact that in passive self-ligation, the force of the arch wire is not modulated by something like an elastomeric ligature. And what this means is that passive self-ligation is much more responsive to any force you put on the appliance. So whereas this might not happen with conventional ligation, certainly forces that you put on with passive self-ligation have a much more apparent effect. And that's what you saw in John Lynn's talk this morning. So what you could do is this. Oh, let me go back. So here's the one that causes compression. And if you do this, you run the elastic from here, what you get is compression, but you get expansion if you run it round here and the molar. And that's what you want in class 2 cases. So in class 2 cases, think about running your elastics from the lower molar to the inside of the upper arch so that you get expansion of the upper arch and compression of the lower. So that almost brings us to the end of the first lecture. And so what I would say is when you see posterior crossbites, they're not always the same. Understand the etiology. Some of them will be due to maxillary collapse because of missing or unerupted teeth. Some will be due to habits, low tongue position, airway problems. So discourage the adverse habits. Learn to see how much natural transverse anchorage is there. If your second molars are in a normal buccolingual relationship, they will provide you with a lot of transverse anchorage to allow the crossbite to correct without any expander. Use light round wires to start with this disarticulation and cross elastics, and then you can go into expanded upper rectangular wires if necessary. Treat adult crossbites with caution. They often don't have a functional shift. They often have some true mandibular symmetry. Remember that with a bit of ingenuity, you can get one elastic to do 2 jobs. So are expanders necessary? Hardly ever. You certainly never need RPE. The only thing that I would say that sometimes it's really tough to correct a crossbite where the second molars and the first molars are both in crossbite. And you might need a little bit of help from a slow maxillary expander just to help kick those molars out. But I'd suggest what you do is try with the elastics, and if that doesn't work, then switch and give them a slow maxillary expander for 3 or 4 visits. How long should you wait? My rule is if nothing happens in 2 visits, then it probably isn't going to work. If I don't see any improvement at all, so I'd give them 2 visits with the elastics where the second molars and the first molars are in crossbite. And if that didn't work, I would give them a slow maxillary expander. But I have to say, I can't remember the last time I did that. So it's a very rare occurrence. So let's change gear. Let's stop and let's look at this. digital orthodontics made easy. And if you hadn't realized, then the future is digital and there is nothing you can do about it. In the future, orthodontics will become digital. Our personal worlds have become largely digital. I'll bet there is hardly any, probably nobody in this room that doesn't have a smartphone, doesn't have a tablet, doesn't have a computer. And Insignia is a fully interactive software system and a fully customized appliance system, which includes brackets, tubes, and arch wires. So when you order Insignia, you get all the brackets, tubes, and arch wires necessary to treat the case. It's designed to give patients an optimal functional occlusion and an aesthetic smile, which is customized to their mandibular skeletal anatomy and also their occlusal anatomy. It's a passive self-ligating appliance, just like Damon, some very small differences, and what happens is you submit data about the occlusion and the patient's face to Ormco. They then straighten the teeth to the final result. They send it to you for checking, and then when you sign it off, they make the fully customized appliance. So it's a sophisticated and integrated tool to improve orthodontic outcomes. So the brackets are placed on the straight teeth in the computer laboratory. Those are then reverse engineered so that they're on the malocclusion, and jigs are made to carry the brackets. And so what happens is that the orthodontist designs the desired outcome in Insignia, and then Insignia plans where the bracket should be placed in order to achieve that outcome. And Ormco Insignia consists of two components. There's a website, ormcodigital.com, which is used for doctor administration, patient administration, and support. And then there is a bit of software that sits on your computer, which allows you to view the cases, customize the cases, and approve them. And the program runs on Windows, but you can run it on a Mac very easily if you have Parallels or Fusion. And if you're going to adopt any new technology, a bit like Toyota's 5 business objectives of quality, cost, morale, delivery time, and safety, here are 8 things you might want to ask. They easily fit into Toyota's 5 categories. So firstly, will it improve the quality of the patient care I give? Will it reduce my costs? Will it generate new revenue? Do I get a return on my investment? Is it easy to use? Can I easily integrate it with the existing technologies in my office? Does it make me more efficient? And does it improve safety? And so these are the sort of questions you should be asking yourself when you adopt a new technology. And there aren't all that many studies on Insignia, but there are several studies on fully customized appliances. And I'm just going to lump them all together on the basis that that's the data that we have. So this is on SureSmile. It was done by Jamie Ma in 2010. They had 2 groups of patients with SureSmile and conventional. Their ABO discrepancy index was 9 and 11, so they weren't very difficult cases. These were pretty easy cases. If you looked at what the outcome was using the American boards, what was then the orthodontic grading system and now is the case radiograph evaluation, the cases that were treated with SureSmile treated out a little bit better, and also they took about 25% less time to treat. So that would suggest, and there are other papers that suggest very similar things, that your treatment times, if you adopt a fully customized appliance, you might expect your treatment times to be shorter. You might expect to have fewer visits and better outcome measures. And those things go quite a long way to satisfying the cost bit and the efficiency part that we would like to see when we adopt new systems. So we plan all this on Insignia. We get this beautiful occlusion. How do we know that's what's going to happen? How do we know we are firstly going to get the brackets in the right place? So this is plan versus actual. Now, you will have all made plans for something, and maybe you are like Jeff Bezos, the founder and CEO of Amazon, who says that any plan won't survive its first encounter with reality. The reality will always be different. It will never be the plan. So mostly when we have a plan, things don't quite turn out as we expect. So how accurately can we transfer the digital setup to the teeth? So this is an in-house study from Ormco, looking at bracket transfer accuracy. They had the original scan, and then they did an intraoral scan immediately after the bond-up on 30 cases. And what they were aiming for was bracket placement accuracy within 1/4 millimeter. And they used this mapping technique. So if the discrepancy was between +1/4 and -1/4, the teeth appeared green. If it was between +1/4 and +0.5 millimeter, they appeared yellow. And these are just 3 cases taken from the study, and you can see that most of the time, these brackets were positioned within 1/4 millimeter of their planned target. So the objective from Ormco's point of view is to achieve a bracket transfer accuracy within 1/4 millimeter of the target. Fine. But actually, what we're really interested in is, does our end result match up to what we planned on Insignia? And there aren't really very many studies that look specifically at Insignia, but here's a study from quite a reputable pair of researchers that looked at Incognito. And I said, we're just going to lump all these fully customized appliances systems together. So they used exactly the same technology, the mapping technology that you've just seen, and they looked at Incognito cases to see how accurate was the plan and how accurate was the finished result. And this is what they found. So here's the mapping technology. You can see the colors. Green and yellow are pretty good, but you can see there are 2 teeth that are blue. And those teeth are the second molars. And second molars are difficult to control. They're on the end of a cantilever. So it's much more difficult to control those teeth than it is for a tooth that has a bracket or a tube either side of it. So the important bit is in orange. Teeth on cantilevers are difficult to control, so you might not get as accurate solution from that. And the other thing is that fully customized appliances tend to over-exaggerate the amount of true expansion that you can get. What you actually get is a bit more tipping, whereas what is predicted is more bodily movement. So we know there are some things that we need to be careful of. But this was a study that looked at something slightly different. It set really tight parameters. It said at the end, they wanted the teeth to be within 0.5 millimeter of the planned position for all the linear measurements and 2 degrees for crown torque, tip, and rotation. So again, they used the mapping technology that you're quite familiar with now. And what did they find? Firstly, they found that the posterior expansion prescribed by the virtual treatment plan was expressed by buccal tipping rather than bodily movement, which is what Dan Grauer and Bill Proffitt found. They also found mandibular incisors had increased labial crown torque. They moved forward, and the maxillary central incisors had increased lingual crown torque. And the reason for this was class 2 mechanics. And they also found they had crown tip discrepancies and rotations, and these were ascribed to the class 2 mechanics and also to intra-arch space closure. And so, when you design these cases, the message is, be careful of the amount of expansion, and your mechanics will affect the final result. And Insignia is a tool to help you produce better results. It's not a bond it and forget it system. You have to have all the usual skill in diagnosis, treatment plan, reading and reacting through treatment, and selection of mechanics. And the other thing is that any fully customized appliance cannot deal with biological factors such as bone density, root anatomy, occlusal forces, and patient compliance. So what do we know? Fully customized appliances, not absolutely accurate, but pretty close. Watch the second molars, watch the expansion, and you have to be able to tell the technicians how you're going to treat the case, because otherwise they can't put in the necessary compensations to make sure the teeth get in the right position. So what we're looking at is appliance performance, orthodontic skill and management, patient compliance, and biology. And we can give you the very best appliance in the world, but if you can't use it, it's useless. It's Wimbledon in England, it's cream, strawberries, sunshine. If you gave me Andy Murray's tennis racket, which I'm sure is a highly sophisticated tennis tool, I can tell you my tennis wouldn't be any better at all. It's a fantastic appliance, but as a tennis player, I'm feeble. So you have to bring all these three things together. So let's just look at a case. This is Paula. She is almost 50. I treated her son, and she said to me, could you treat me? And I said, oh yeah, that'll be fine. We'll treat you. So here's her profile. And here is her malocclusion. So this is not a difficult malocclusion. We did the bond up in February 2016. Here's her tracing and her calf. Nothing very remarkable to look at there. Here are her start of treatment photographs at the top and Insignia's translation of the models into what's called T1, the start time point. And you can see that, of course, the molar relationship looks a little bit worse on T1 than it does in real life. And I would just like you to look at here. Look at the upper left canine, which has excessive labial crown torque, and the rotation of the lateral incisor. And John Lynn talked about variable torques, and Frank Bogdan talked about variable torques. So what torque do you think should go on that tooth? Should it be high torque? Should it be standard torque? Or should it be low torque? Well, we don't have to make that decision because Insignia is going to make the choice for us. So she was half a unit class 2 on the right, full unit class 2 on the left. Here you can see the rotation of the lateral. And here you can see the torques that Insignia has suggested. And just in case you find it difficult to read, here's the upper canine here. It wants minus 1.9 degrees on the right and minus 0.4 on the left. So it wants less torque on this tooth than on this one. And you might have thought it would be the other way around, that you would want to tuck this tooth in a little bit, whereas the torques are very much the same. So let's watch what happens to this tooth. So here we have bonded her up. This is about her first adjustment visit. And if you look at this tooth, we're in round wires. Do you think it's got better? Do you think it's stayed the same? Or do you think it's got worse? And I think it's got a little bit better. And one of the things that I think Insignia does for you is it calculates better the interactions between all the different teeth than we can sometimes do manually. So we've got some triad gel disclusion behind the upper incisors. We gave her Quail 5/16 short 2.5 ounce 60 gram elastics to start correcting her class 2. You can see here, I think this tooth is improving, although we've never gone into rectangular wire. The inclination of that tooth is changing. So we're still in round wire, and you can see that while I'm quite happy that this is going to sort itself out, I still have rotations here. So there's the canines. Here are the bite turbos behind the upper incisors, and still this little rotation here, but we're still in round wire. So give Insignia a chance to work. We now switch her to Penguin 3/16 3.5 ounce 100 gram elastics just to do some class 2 correction. We're in rectangular wire. This is improved, but it's not perfect. And I wanted to, I was once lecturing in Tehran, and they described this reshaping as manicuring. So I quite wanted to manicure the edge of this tooth to get rid of that flatness. I wanted to manicure the edge of this here. I wanted to do a little bit of adjustment of her crown height here. And she had a tiny black triangle, so I just wanted a tiny bit of IPR. But Paula said she didn't want any of that sort of thing done. She's actually a dentist. She was surprisingly resistant to having any sort of active intervention on her teeth. And you can see that this isn't quite there. I'm in a rectangular wire, and it's not quite there. So finally, it looks a bit better. Our midlines are on. I decide that we're going to put a little bend in. So we just put a little bayonet bend in to rotate that round and finalize it. And that's the only bend we did. She didn't have any finishing elastics. It was 14 months of active treatment. This is where Insignia said we would end up. This is where we actually ended up. Here's her upper and lower arches. Here's her smile at the end of treatment. And here's her profile at the end of treatment. So this is the start and the finish, just 14 months. Remember how class 2 she was. You can see how the upper arch has rounded out nicely. Here's the lower arch. Here's the start and the finish of her facial full face. Smiling. And here's the change in her profile. And I don't know whether you think her profile looks better at the end of treatment than it was at the start. I don't think I can. If you do, I don't think I can claim any credit for that. I think she's just a bit more relaxed than she was at the start of treatment. But definitely her lip architecture, I think, looks better at the end than at the start. So, data submission. You have to be able to submit the data to Ormco. Just put up your hand if you've got an intraoral scanner in your practice. So most of you don't. I think that will change quite rapidly. I think you will all, 5 years' time if we did this, the people that put up their hands will be the people, it will be the same number that don't have intraoral scanners. But we're doing a research project in Newcastle. We got some money from Invisalign to do a research project because there's still a lot we don't know about intraoral scanners. Intraoral scanners came to us from restorative dentistry. How many of you have had an intraoral scan done on you? Keep your hand up. Not many. Not many. Did you like it? Yeah, you liked it. It's interesting, not everybody likes it. It takes, and there is a study that shows people prefer having alginate impressions because they're quicker. They're not terribly pleasant. But actually, I went into somebody's practice and they said, oh, we've got a new iTero scanner. It'll do a scan in 2 minutes. And I said, great, scan me. 20 minutes later, we were still doing the scan. And we are in a bit of a learning curve. I think they're great technology. And this was a systematic review that looked at scanners and just said that we don't have a lot of evidence on the validity, repeatability, and reproducibility of full mouth scans. And there's not much evidence on how accurately they can record intra-arch measurements. And there are few studies on children. They came from restorative dentistry in adults. But just remember, lots of our patients have small little mouths. And the wand on a scanner is quite big. So we need to know what's the best way to scan for children. Can we have smaller wands? I'd like to be able to scan the palate. Now, you can scan the palate, but still there aren't all that many studies. And most of the studies are done on class 1 malocclusions. And we need to know a bit more about the accuracy of scans on class 2 and class 3 malocclusions, and also dentition that have spaces in them. That's not to say we shouldn't use scanners. Of course we should. I think they're a huge step forward, but we should just be a little bit careful. So for most of you, I think you'll be doing this. You'll have to send in PVS impressions. You have to use a PVS impression. I prefer to use this. It's Kerr Take 1. It's a one-step PVS impression that consists of a putty and a wash. So you put the putty into the impression tray. You have a plastic wafer. You put it quickly in the mouth, take it out, remove the wafer, and then you cover it with the wash. So I use the fast set. You have a working time of about 90 seconds, a minute and a half, and it sets by the time you get to 4 minutes. And it's really important that you stick to this, otherwise you'll get impressions returned because they'll have drags on them. Like most orthodontists, I think you probably don't read the instructions for all the materials you use until it goes wrong. That's what the manual's for. Read it when it goes wrong. But I would just say, for this, you need to make sure you stick to the times. And you will get an impression that looks something like this. So the orange is the wash. The blue that you can see is the putty. You want to have as much orange, really, as possible. You'll always get a bit of putty showing through, but make sure that you don't seat the tray too firmly so you get a nice layer of wash. Sometimes you will get impressions returned to you because they're not of adequate quality. And this was returned to me. And you can see they very helpfully sent me a photograph with a little arrow saying they don't like this here. And if I look at that impression, I don't think that looks too bad. I can see all the gingival margin. So I thought, what on earth are they playing at? Why? What's wrong with this? And the answer was this. When I took the photographs, the 5 hadn't erupted. So Insignia were just being really careful and saying, are you sure you've got this right? Are these photographs, does these photographs and these models belong to the same patient? Which indeed they did. So it's really important that you give instructions to the Insignia technician, because we have already shown that how you treat the case will affect how the case is set up. So we don't have a lot of time to talk about torque compensation, but Insignia has something in it called torque compensation, which says once the tooth moves more than a certain amount, it will apply torque in the slot to try and keep the tooth at the correct inclination. And mostly, I set all my cases up with torque compensation on. There will be other people who set their cases up with torque compensation off. Sonia, I think do you set yours up with torque compensation off? Off. I set mine up with torque compensation on. I think it's a matter of personal preference. The torque compensation is much less if you specify you're going to use a 2125 wire. So I would always have a 2125 copper night-eye wire in the list of wires that I order to make the torque compensation minimal. There are 2 indications when you when you must switch the torque compensation off, and that is in orthognathic surgery, because you don't want any, you're trying to decompensate them. You don't want any compensation. And the other is, I think if there's a high risk of gingival recession, I turn the torque compensation off. You can turn the compensation off, ask the technician to turn the compensation off on specific teeth. You don't have to do it arch by arch. So when you submit your case to Insignia, you will fill in a case, a form like this. You can have pre-chosen profiles. So you can have a profile for clear brackets. You can have a profile for metal brackets. But the important thing is to fill in the bit about the treatment plan. And I think there are 3 things you need to tell the technician. You need to tell them what's wrong with the case. And I just thinking about it in terms of anteroposterior, transverse, and vertical, and any pathology is, so you don't have to write them an essay. You make it pretty short. You need to say, where do I want to end up? Where do I want my upper incisors to be? Are we going to have any extractions or leave any spaces? And what is the final position of the molars and the canines going to be? And then finally, you need to tell them how you're going to do it. So you have diagnosis, treatment, and method. So how am I going to get my upper incisors in the right position? Am I going to retract them? Am I going to extrude them? Am I going to correct the class 2 with short elastics? Am I going to, and you can say that you're going to upright the teeth over the basal bone using Damon arch form, whatever you need for the specific case. So the key to successful treatment is getting the upper incisors in the right place. And you need to think of this again in terms of ATV, anteroposterior, transverse and vertical, and inclination. And in terms of the AP position for the upper incisors, if you go between the hairline and the facial axis point on the forehead, so that's the midpoint of the forehead, and glabella, which is here, the upper incisors usually lie between a vertical drop between here and glabella. So that's where you want the teeth ideally to be. You need to tell the technician what midlines are coincident with the face and which are dentally off. So in this case, the upper center line is off to the right. If you again look at the upper arch, you can see this is another of those arches where there has been significant collapse. So here you can begin to see the collapse, and here you can see this is the 7 as it's come forward, so the arch has narrowed. So we have an asymmetric upper arch, and here you can see the upper midline off to the right, and you need to tell the technician that, because otherwise he really won't know. Here's somebody with ideally positioned upper incisors. If you look at the inclination of the upper incisors, it's easy to tell when it's correct without having a kef. If you just look at the lower 2/3 of the tooth, that should be at 90 degrees to the Frankfurt horizontal or the natural head position. So that's how you can tell where the upper incisors should be. And you can also tell that the lower incisors, the labial face of the lower incisors, should be at 90 degrees to the occlusal plane. So you don't really need kefs, and you can use this to decide what inclination you want your incisors to be at and where you want the upper incisors to be positioned. When you choose the method, just make sure you go for a reasonable amount of expansion if that's what you want to do. Make sure you can fit the maxilla around it. Make sure you have a plan to get the upper and the lower incisor position correct, and tell the technicians how you're going to achieve the buccal segment relationship. So when you come to set up your Insignia case, Insignia will send you something like this, where the case is set up and allow you to make modifications. And there are some things that I fairly routinely do, and I'm sure Sonia will give you some other tips. I lift up my second molars by 0.5 millimeter out of occlusion. And I give them 5 degrees of distal tip. And I also give the first molars 5 degrees of distal tip. And I'll show you the reason for this in a minute. But particularly in class 2 cases, remember that the tooth is going to tip about the center of rotation. If you have any mesial tip in a class 2 case, it becomes very difficult to correct the molars to class 1. So 5 degrees isn't much. And the reason for this is that this is why we have a curve of Spee. It's because so that the forces on the molars, which are our most powerful biting teeth, are directed through the key ridge. So in general, these teeth gently, very gently tip back as we go distally. They're not set absolutely straight. So I do that pretty routinely on most of my cases. And if you have a case that has hypodontia and you're going to plan to replace this tooth, either with a resin-bonded bridge or perhaps an implant, I give 5 degrees of root divergence either side, just to make sure I get those roots diverged without me having to do any arch wire bends. The tip error on a 1925 arch wire and an 025 by 02 slot is about 1 degree. So this will just give me a little divergence or make sure that my roots are parallel. And we have quite a lot of cases in the UK that are missing upper lateral incisors. And the other thing that I would suggest that you do is when Insignia send you back this beautiful occlusion like this, you ask them for lateral incisor brackets, because you will need those to provide a temporary lateral. And the first time I did this, I forgot that, and I had to write off and say, please. But now I know if I've got missing teeth, I'm going to put a tooth on the wire, order up the brackets. So let's finish up by looking at Melissa. And you've already seen Melissa. And she's a young dentist. She's been qualified about a year and a half. She was on my clinic, and she said, oh, Mr. Burney, could you treat my crossbite? Oh, it seems to have jammed. Let's just come out of it and go back in. It's completely jammed. Okay. Let's restart it. So she came in, and she was the girl that had the 2 premolars in crossbite. Just froze, so I'll just restart it. She had the 2 premolars in crossbite, and we showed how easy it was to correct that. And she provides us with one important lesson in planning insignia cases. So this is the other case. Success. So this is Melissa. Here's her profile. And here's her occlusion. And you can see the crossbite on the left-hand side, and take a very good look at her lower arch. Here you can see that her center lines are off. She's got a bit of a mandibular shift. Here's the crossbite that you can see. And here is her tracing. So we bonded her up. I've put a traction hook on the lower left canine. We've put turbos behind the upper incisors here. And then at the next visit, I can put a bracket on this. I can get rid of the traction hook and put a bracket on that tooth. And look very carefully. The upper arch is beginning to sort itself out quite nicely. We've got a bit of a lateral open bite here, but we've still got the turbos. But look what is happening to the lower arch. See if you can see what is happening. And this is what is happening. We started off like this canine here, and it's moved to here. And that was not part of my planned tooth movement. And the suggestion is that if you're unhappy about tooth movements in insignia, you should wait and let them work themselves out. So here we are. It's not getting any better. We give her some triangular elastics just to flatten out the arches, rabbit elastics. And you can see here that this tooth definitely is not quite right. We reposition the bracket on this tooth. So we've repositioned it. Here you can see the repo. If you have to reposition these, just gently take them off, sandblast the back, and then rebond them by eye, because I think the tooth was in the wrong place. And here it looks to me as if it is in a much better position. So why did it happen? So the first thing when you get something like this is go back to the setup. So this is the setup for the lower arch. And you can see the alignment of this tooth looks really quite good. So why go wrong? Well, the important thing is that you have to move the three-dimensional image. And you can see here that this setup was wrong. The technicians didn't notice it, and I didn't notice it. And it's easy to miss if you only look at it from on top. So you need to make sure you rotate the image to make sure that it gets in the right place. So we did a little bit of interdental stripping because she had a tiny black triangle. You can see that the rest of this is beginning to sort itself out quite well. It's typical of Insignia. You get these really good finishes in the buccal segments. Everything begins to look really good. Here's the tooth, now aligned. And here she is when I saw her at the end of May, and we're pretty nearly finished. We've just got a little bit of finalization to do here, and she'll be out and have completed treatment in about a year. So, just to summarize, it's 12:30. We've talked about what you can expect from fully customized appliances. We've explained that the target for bracket positioning is within 1/4 millimeter. We've talked about what to look out for in terms of helping to tell the technician what they want. This isn't a bond it and forget it appliance. You need to have all the skill that you have and a cooperative patient to make it work. We've talked a little bit about PVS impressions versus IO scanners, instructions to the technician, and Insignia design tips, and troubleshooting when things appear to go wrong. So just to say thank you very much for listening. And enjoy Insignia. Thank you very much.
Thank you, David. As always, it's a pleasure listening to you, and thank you for the material. Enjoy lunch, everybody. We have a 1-hour break. Same as yesterday, served in the foyer, so enjoy.
Okay, good.
Nicely done.
Thank you very much.
Thank you.
Yeah, it's never happened before.
It always happens when it's the biggest group.
Yeah. Anyway.